Hello, this is Elena Coucher. I will be presenting to you nursing care of the postpartum patient, and we will also be discussing the complicated postpartum patient. The postpartum period is a 6-week interval between the birth of the newborn and the return of the reproductive organs to their normal non-pregnant state. Is referred to as the puerperium or the 4th trimester of pregnancy. It's important to note that we do have some national health goals that are related to women's health and the postpartum period. We want to reduce maternal mortality from 7.1 per 100,000 live births to 3.3. We want to reduce the proportion of live births occurring within 24 months of a previous birth from a baseline of 11% to 6%. We want to increase the proportion of mothers who breastfeed from 64% to 75%. Now, we will discuss more about breastfeeding in the newborn lecture. However, I do have some things I want to address on these national health goals. Let's talk about that. Not every woman and infant are successful at breastfeeding, and it's time that we realize that in healthcare. There have been many reports, I have seen them lately, of women who proceed to breastfeed even though their infant shows signs of hunger after the time that the milk should be in, which is usually 3 days post-delivery. We want women to be successful, but we need to provide them with appropriate teaching of hunger cues for the infant. Again, not every woman can be successful at it. So though I think that breastfeeding, and I'm a very big proponent of it, also I'm a proponent of, if your baby's hungry, to feed them. Now, within the first 3 days after delivery, they're going to go through a period of where we call marathon nursing, where they latch to the breast and they nurse and they nurse and they nurse and they nurse. They're trying to get that milk to come in. After about 2 weeks, if we're still showing signs of hunger cues and they've gone back to their pediatrician and their baby has not gained back their birth weight or even close to gaining it back, that is where we need to, in healthcare, start encouraging these moms to actually look at supplementing their infants. But again, we'll talk more about that in the newborn nutrition lecture. So our reproductive system and the associated structures, this lecture goes right along with your lecture outcomes, which we will probably be discussing within the classroom. Involution process is a return of the uterus to a non-pregnant state following the birth. It begins immediately after the expulsion of the placenta. Where the placenta was implanted is sealed off to prevent further bleeding. Secondly, the organ then returns to an approximate pregestational size. The uterus is also referred to as the fundus in the postpartum setting. You will hear that often used. The involution process, immediately after delivery, the uterus is found by palpation at the midline and about 2 centimeters below the level of the umbilicus. When the woman becomes 12 hours postpartum, it rises once again to about 1 centimeter above the umbilicus and decreases in height a minimum of 1 to 2 centimeters per day. At postpartum day 9, we should be unable to palpate it. Subinvolution is the failure of the uterus to return to a non-pregnant state. Most common cause is retained placental fragments and infection. Within 12 hours after the delivery, the fundus may be approximately that 1 centimeter, I'm going to say it again, above the umbilicus. The fundus then starts to descend about 1 to 2 centimeters every 24 hours, and by 6 weeks postpartum, when the patient has gone in for a follow-up appointment, the fundus is normally halfway between the symphysis pubis and the umbilicus. Contractions. Postpartum hemostasis is achieved primarily by compression of the intramyometrial blood vessels as the uterine muscle contracts. This is achieved by several different things. Hormone oxytocin that is released from the pituitary gland, which causes the uterus to contract. Pitocin, which is and can be administered IV or IM immediately after expulsion of the placenta. Breastfeeding moms also will stimulate the oxytocin release, And then massage of the uterus after the placental delivery, a fundal massage. A fundal massage is an essential nursing intervention following delivery of the newborn. The placental site is healed by endometrial regeneration and is not complete until 6 weeks after birth. The lochia, that's the post-birth uterine discharge. There are 3 types. You have the lochia rubra, which consists mainly of blood and decidual or trophoblastic debris. First 2 hours after birth, the flow should be like a heavy menstrual period, and that should continue 1 to 3 days with a bright red to dark red color. The lochia serosa consists of old blood, serum, leukocytes, and tissue debris. It typically lasts 4 to 9 days and is dark reddish brown to pinkish brown. And the lochia alba, that consists of leukocytes, decidua, epithelial cells, mucus, serum, and bacteria. And this may continue for 2 to 6 weeks, and it can be yellow to white in color. The amount varies from patient to patient with activity level. Heavy to moderate flow initially during the recovery period is reflective of the uterine tone. They might saturate a perineal pad in about an hour. A moderate flow is less than 6-inch stain on the perineal pad. When you have a light flow, you're probably going to see around a 4-inch stain on the perineal pad. Scant would be only on tissue when the perineum is blotted or less than 1-inch stain on the pad. Any woman who experiences any abnormal amount of vaginal bleeding soaking through more than 1 pad in an hour, that is abnormal, should be further evaluated. For instance, a firm fundus that is midline and at an appropriate level, according to hours or days after postpartum, this would be, that's an expected finding. However, if this is the nursing assessment and you still find the woman continues to bleed heavily, soaking through the more than 1 pad in an hour, then it is important that we call and talk with the OBGYN. We need to let them be notified. There may be something else that's underlying going on. Persistence of lochia rubra early in the postpartum period suggests that continued bleeding is a result of retained fragments. There again, you have a firm fundus and it's midline, but she's continuing to have heavy bleeding. Then we are going to suspect that underlying cause would be the fragments of placenta or the membrane. Recurrence of bleeding about 10 days after birth is from the healing placental site. Any bleeding that occurs 3 to 4 weeks after birth may be caused by infection or subinvolution. Continued flow after 6 weeks may indicate endometritis, in particular if fever, pain, or abdominal tenderness are present. The reproductive system and associated structures we're still talking about, and what's going to be happening to this woman as she's recovering. The cervix is very stretchy immediately after birth, but by 18 hours postpartum it is shortened and becomes firm as well as has regained its form. It gradually closes but leaves a horizontal opening rather than a circular one. Childbirth takes a toll on the vagina and the uterus. Injuries may occur as a result of delivery. So what ends up happening is that it gradually returns to the pre-pregnancy size by about 6 to 8 weeks after childbirth. The perineum initially is bruised and edematous, especially in the area of the episiotomy or laceration repair if this occurred. It's best assessed by having a patient on their side with their upper buttock raised or lithotomy position. We want to observe for signs of infection, excessive bruising, and a hematoma. Healing should occur within 2 to 3 weeks. We also have to assess for hemorrhoids, which may worsen after pushing during birth. They usually decrease in size within 6 weeks. A woman who has hemorrhoids will do well with a sitz bath. It's very comforting for her. We also want to provide her with some local anesthetics for hemorrhoids, and also digital pushing them back up digitally into the rectum if they are external can sometimes bring a little bit of relief to the mother. So those are three things that we know of that can comfort her during that time when those hemorrhoids are out there because she's been pushing during childbirth. We also want to talk to the mom about discharge. We need to talk to her about things that she can do to increase that pelvic floor strength, and that's doing Kegel exercises. That'll restore, it'll strengthen the pelvic floor muscles. It's part of discharge teaching to the postpartum mom. And of course, if you don't know, I will go over it again. You have to pretend like you're holding a flow of urine in midstream, and do that about 10 times every hour. The endocrine system, placental hormones, with the expulsion of the placenta results in a dramatic decrease of the hormones produced by that organ. Decreases in human chorionic somatotropin, estrogens, and cortisols. Reverse also the diabetogenic effects of pregnancy. Decrease in the placental enzyme insulinase results in significantly lower blood sugar levels. But we'll have to monitor type 1 diabetic patients closely as they might require less insulin during that time. Estrogen and progesterone levels drop markedly and reach lowest levels at 1 week postpartum. Pituitary hormones and ovarian function, prolactin, the levels rise progressively throughout pregnancy. In the breastfeeding women, prolactin levels remain elevated into the sixth week after birth. In non-breastfeeding women, prolactin levels decline after birth and reach pre-pregnant range in 4 to 6 weeks. Prolactin levels affect ovulation so that women who breastfeed typically ovulate later. Typically, not guaranteed. The first days after birth, the abdomen still protrudes and gives us still, that pregnant appearance. During the first 2 weeks after birth, the abdominal wall is relaxed. It takes about 6 weeks for the abdominal wall to return almost to its non-pregnant state. Skin regains most of its previous elasticity. They get return of muscle tone, and that'll depend on their previous tone as well. Proper exercise and the amount of adipose tissue. Occasionally, the abdominal walls separate. I don't know if you've ever seen, I actually saw a picture not long ago, and I wish I'd had put it into the slideshow, of a woman who was an athlete, and she had a six-pack, and after she delivered both of her babies, her abdominal wall muscles had separated, and it really gave an awkward appearance to her abdomen. The urinary system, structural changes that we have dilation of the renal pelvis and ureters begin to decrease. There's also a fluid shift. They have rapid diuresis that causes as much as a 5-pound weight loss over early postpartum, and that usually begins in the first 12 hours. That's caused by changes in abdominal pressures, loss of fluids that were present during pregnancy, and then the drops in those estrogen levels. The bladder and urethral recovery, the urinary tract has a possibility, especially if catheterized during and after delivery. So we have to monitor our moms for any possible signs of urinary tract infection. Bladder tone is diminished, and that's related to overdistension during labor. It could be bladder trauma from the fetal head pressure during contractions and the birth. Bladder tone is usually restored by 5 to 7 days after birth. And the effects of anesthesia also give them a decreased urge to void. We have to monitor closely for urinary retention. This will increase the bladder size, and also this displaces the fundus and creates an environment conducive to increased bleeding. When assessing the fundus, if you notice that the mom has a shift in the fundus, if it's not midline and it's shifted, then the suspicion is that the bladder is full. We want to encourage that mom to empty her bladder. If she's unable to urinate related to the trauma, then we may have to do an in and out catheter on her. The gastrointestinal system, the appetite, mothers typically are very hungry and thirsty immediately after birth. They give birth, the first thing that a lot of them want to do is eat and drink. Breastfeeding mothers require more caloric intake. The bowel sounds may be sluggish after regional anesthesia and C-section. It is imperative that you listen for bowel sounds and you assess for if they have passed any gas following a C-section. They are at risk of an ileus. They're also at risk for bladder or bowel nick. So these are the things that we have to assess completely and thoroughly on them. They may not have a bowel movement for 2 to 3 days after birth, and if those of you that have been in postpartum have seen, we typically give our C-section moms and our C-section moms a simethicone, and both vag and C-section get a DocuSet every single day, and I think the DocuSet is twice a day, and a simethicone is up to 4 times a day. May have trauma to the anal sphincter muscle or damage to the innervation of the pelvic floor. So we want to make sure that we're giving them the medications, and we encourage them when they go home to go ahead and take that stool softener. We want them to, the first time that they have a bowel movement, that it comes out nice and easily. We want a soft one. We don't want them to have a hard one. Breastfeeding mothers, before lactation begins, breasts feel soft and colostrum can be expressed. After lactation begins, the breasts feel warm and firm, and tenderness may persist for about 48 hours. When we are assessing our postpartum moms, we need to assess her nipples for signs of irritation from breastfeeding, such as cracks, blisters, or reddening. If I'm seeing that a mom has blisters to her nipple, that I am going to assume that baby is not latching correctly, and I need to do something as a nurse to intervene so that she doesn't end up with any additional trauma. For non-breastfeeding mothers, colostrum is present for the first few days after childbirth. On the 3rd or 4th day, postpartum engorgement will occur. Breasts are distended, firm, tender, and they're warm to touch. Milk is present, but they do not need to express it. The discomfort usually decreases within 24 to 36 hours. Breast binder or Tylenol, those may be used to relieve the discomfort, and lactation ceases within a few days to a week. Whether the book mentions it or not, to relieve discomfort and dry up the breast from the milk, a mother can actually apply cabbage leaves to the breast and wrap her chest with an ACE bandage. In our cardiovascular system, the blood volume changes in blood volume after birth depend on several factors, such as blood loss during childbirth and the amount of extravascular water mobilized and excreted. Blood loss results in immediate but limited decrease in total blood volume. Most of the blood volume increase during pregnancy is eliminated within the first 2 weeks after birth. Women can tolerate a considerable blood loss during childbirth. However, the average blood loss for a vaginal birth of a single fetus ranges from 300 to 500 mils. Typical blood loss for a C-section mom is more in the range of 500 to 1,000 mils. We're still talking about the cardiovascular system. 3 postpartum physiological changes protect the woman by increasing the blood volume and prevent hypovolemic shock with a normal childbirth blood loss. Elimination of the uteroplacental circulation, loss of placental endocrine function that removes the stimulus for vasodilation, and mobilization of extravascular water stored during pregnancy increases the blood volume. Though the typical woman can handle experiencing the large amount of blood loss, this does not mean, y'all, that she cannot experience some hypovolemic shock. I would want to assess my woman who has experienced a great amount of blood loss with resulting labs that support that. I'd want to look at her vital signs. Is she experiencing tachycardia? Make sure she isn't dizzy, because for safety reasons, we want her to call for assistance when getting out of the bed. The vital signs: temperature may be slightly elevated the first 24 hours, and this is caused by hormonal shifts, dehydration, muscular exertion from labor. If elevated after 24 hours, it could be indicative of infection. Pressure may have a small rise for about 4 days. Infection can be a very real possibility following delivery. It is essential we assess our women for any signs and symptoms of infection. A client's temp must be taken every 4 hours while she is awake. Temps up to 100.4 in the first 24 hours after birth often is related to the dehydrating effects of labor. An appropriate action for us is to have her increase hydration by encouraging oral fluids, which should help bring that temp to a normal reading. Diaphoresis and chills is not a factor of body temperature, but a vasomotor instability due to labor and delivery process, and or epidural side effect. Diaphoresis is related to shifting of excessive fluids into the extravascular compartment. It usually occurs during the first few nights of a postpartum stay. The pulse may be elevated for the first hour after childbirth, then it decreases to normal. A rapid pulse, or one that is increasing may indicate hypovolemia as a result of a hemorrhage. Tachycardia is not a normal rhythm. You need to remember that. Tachycardia is not a normal rhythm. We do not want to see a woman with a 110 pulse. We don't want to see it going up to a 160 pulse. That is not normal. Blood pressure, it gets altered slightly, if at all. Orthostatic hypotension can occur during the first 48 hours postpartum, especially the first time the woman gets up after delivery. A low or decreasing blood pressure may reflect hypovolemia also, secondary to hemorrhage. The patient may report dizziness or lightheadedness upon standing, so we have to instruct that patient to call for assistance when getting out of the bed. We have a lot we're saying about the cardiovascular system. Blood components, hematocrit, hemoglobin. During the first 72 hours after birth, there is a greater loss of plasma volume than a number of blood cells. This results in a rise in H&H by the 7th day after birth. Normal values typically return by 8 weeks after birth. The white blood cell count, normal white blood cell count of pregnancy is about 12,000. Normal white blood cell count does increase during the first 10 to 12 days after birth, and it can go up to 20 to 25,000, and that can be common. Coagulation factors, we have to look at clotting factors, and fibrinogen levels are normally increased during pregnancy and will remain elevated in the immediate postpartum period. It causes an increased risk of blood clots, especially after a C-section. We need to walk our ladies. The neurological system, lessening of general edema is secondary to the non-pregnant state. Elimination of the edema relieves carpal tunnel syndrome by easing compression of the median nerve. Numbness and tingling of the fingers, and that occurs in 5% of pregnant females. It will disappear after birth, typically. Headaches require careful assessment. PIH, stress, leakage of CSF into the extradural space. They could have a headache secondary to blood volume changes. It varies from 1 to 3 days to several weeks. Do not discount a headache from a postpartum client. They very well could be experiencing one from CSF leakage and may require a blood patch to stop the leak and alleviate the headache. These headaches do not typically diminish with meds, and the patients will report a hypersensitivity to light. In the musculoskeletal system, the joints will be completely stabilized by 6 to 8 weeks after birth, and they may have a permanent increase in shoe size. In the integumentary system, the chloasma disappears, hyperpigmentation of the areola, and the linea nigra may not regress completely after childbirth. The stretch marks, they very well can have stretch marks to the breasts or abdomen and thighs. They may fade, but they don't usually disappear. Spider angiomas regress, and profuse diaphoresis is the most notable change. The fourth stage of labor is the first 1 to 2 hours after birth. Crucial time for mother and baby, recovering from physical process of birth, but also becoming acquainted with each other. Maternal organs undergo initial adjustment. to the non-pregnant state and the functions of the body systems begin to stabilize. Newborn transition from the intrauterine to the extrauterine existence, and it's an excellent time for moms to initiate breastfeeding because the infant is in an alert state. It also aids in the contraction of the uterus and can help prevent postpartum hemorrhage. When we're doing our assessment, during the first hour, physical assessments are frequent. All factors are assessed every 15 minutes except the temp, which is assessed at the beginning of recovery and again at the end of recovery. If stable after 1 hour, assessment is usually done every 30 minutes in the second hour and then on a routine schedule. For a postpartum assessment, you can remember this acronym. Sorry that I butchered that. B is for breast, U is for uterus, B is for bladder, B is for bowels and rectum, so you're looking at hemorrhoids, L for lochia, E for extremity, H for home and sign, or E for emotional status. Bublier, I guess is what you would want to, how you would want to say that. With the Fundal Assessment, position the woman with knees flexed and head flat, just below the umbilicus, cup hand and press firmly into the abdomen. At the same time, stabilize the uterus at the symphysis pubis with the opposite hand. If the fundus is firm, with the uterus at midline, measure its position relative to the woman's umbilicus. If the fundus is not firm, we need to massage it gently to contract and expel any clots, then measure its position. If the fundus is deviated to the side and above the umbilicus, most likely the cause is bladder distension. We want to assist the woman to void or insert a urinary catheter, then reevaluate fundal position. When assessing the fundus, the expectation is to find it firm and midline positioned. However, if assessing and finding a boggy or displaced fundus, we must ascertain the last time the patient voided and assist them to the bathroom and assess again. When urinary retention is present, the bladder becomes overdistended, which lifts and displaces the uterus. Complications such as postpartum hemorrhage and UTI may occur. The perineum, we need to inspect the perineum with the woman in the Sims position, lying on her side with her back to you. You want to observe for hematomas, erythema, edema, intactness, and the presence of drainage or bleeding from the episiotomy stitches. Interventions for episiotomy care. Usually it heals in 5 to 6 days. We may apply anesthetic spray, and we usually do. Use ice for the first 24 hours only, then warm cloths or sitz baths. Sitz baths for 20 minutes 3 to 4 times per day. We want to promote perineal exercises, help to decrease edema and relieves discomfort. We want to provide pain management with topical medications with lidocaine in those. Oral pain meds such as Percocet, ibuprofen, or Toradol. We usually give that within the first 24 hours post-delivery. We should not use aspirin, though, due to the interference with blood clotting. Post-anesthesia recovery. Recovery from anesthesia requires that emergency equipment is available. With general anesthesia, the patient should be awake, oriented to time, place, and person. Respiratory rate should be within normal limits with O2 sats level at about 95%. Patient may be drowsy, especially if they've had narcotic pain medications that were administered. Regional anesthesia, you assess the patient for level of sensation in the lower extremities. Before leaving recovery area, the patient should be able to move both legs. But we do get them over to postpartum many times where they still are not able to move both of their legs. The patient will start to report that they have tingling sensation as the feeling returns. It may take 1 to 2 hours for anesthetic effect to disappear. Although some patients with post-op epidural PCA report numb spots on the lower extremities, so we have to assist them with ambulation. Once a patient has transferred to the postpartum unit, after the recovery period, the patient will be transferred. The infant may or may not be with her, depending on the hospital policy, depending on if the infant has had to go to NICU. Detailed report must be given to postpartum staff. We look at all aspects of this when we're given a report. We look at gravity and parity. Is she a gravida 1, peri 1, gravida 2, peri 2, gravida 1 and peri 2. Age, anesthetic used, any medications used. We need to let them know what the duration of the labor and time of rupture of membranes. These are important for us to know as a postpartum nurse. Type of birth and any repair, and if any oxytocin was used. Some other things that we have to consider with the postpartum mom that we need to know about. We need to know her blood type and RH status. We need to know her group B status. Is she group B positive, negative? What's her rubella immunity? Prenatal lab screening test. We need to know if she has any IV fluids infusing and what's still going. Is this her first bag of pit or second bag of pit? If it's her second bag of pit, then we're probably going to want to watch her a little closely because she might have actually had some additional bleeding back there that required a second bag of pit. It's all going to depend on the woman. Physiologic status since birth, what's her fundus like, lochia, bladder, perineum, sex and weight of the infant, time of birth, who's a pediatrician, the chosen method of feeding, and any abnormalities. We also want to give a report on the infant, and we need that as a postpartum nurse. We need to know what the infant's APGAR scores were, especially since we do couplet care at Baptist. We need to know their weight. Have they voided yet? Have they stooled? Whether fed since birth, and if infant meds have been administered, and if any lab work was obtained on the infant. Now, this is transferred to the postpartum unit, but let me just tell you, when you're given a report on the postpartum unit, the postpartum nurse who's taking care of your patient is going to want to know all of this information as well. So this is continuity care. You want to pass this information on. It comes from labor and delivery, it comes to you, and from you, it goes to the next nurse who's following and taking care of this patient. Laws relating to discharge, Newborns and Mothers Health Protection Act of 1996 provided minimum standards for health plan coverage for mothers and their newborns. All health plans are required to allow the new mother and newborn to remain in the hospital for a minimum of 48 hours after birth for vaginal delivery and 96 hours for a C-section, unless the MD and mother decide upon an earlier discharge. So the care management, we're talking about physical needs, ongoing physical assessment. Remember the acronym. This should be thoroughly evaluated each shift. Focused physical assessment includes, and you've got the acronym. In addition, we also need to look at when we're looking at our vital signs. We need to look at routine lab tests. We need to look and see what our urinalysis or H&H say. What are we going to implement in the postpartum setting? Nurses in postpartum assume many roles while caring for new families. We direct physical care. We teach the mother about baby care. We provide anticipatory guidance and counseling. We also encourage and support the woman. Infant security is also top on our list. It's become an issue in recent years. Nurses must verify the mother and infant ID bands. Security of the hospital should be explained to the family. Infants are not to be carried from the room in anyone's arms. They should always be transported in a crib. We want to look at prevention of infection. Nurses must educate patients on how to properly care for their episiotomy site or abdominal incision. We need to talk to them about their signs and symptoms of infection that need to be reported. Prevention of excessive bleeding. The most common cause of excessive bleeding following birth is uterine atony. The most important intervention to prevent this is maintaining that good uterine tone and preventing any bladder distension. Augmentation of labor and macrosomic or LGA infants may cause excessive bleeding or postpartum hemorrhage, and so we have to assess those patients carefully. We have to monitor that lochia flow. We need to educate the patient on normal bleeding and what to report. Monitor for any bladder distension and encourage the patient to void frequently. She should be assisted to walk for the first time. And if she's experiencing dizziness or lightheadedness, she needs to be assisted to get up and walk with anything that she does until it resolves. She may have difficulty voiding the first time and may need assistance. We can try our best to do so without having to use an in and out catheter. So we can do running water. We can pour warm water over the perineum to help initiate that. Another thing is something that I have learned to teach patients over the years is that if they're having a little difficulty getting that urine flow going, especially since they've had trauma to the perineum, after vaginal birth or even after a vaginal hysterectomy, I know we're not talking about those right now, but it's the same concept. I would just have my patients to lean forward just a little bit, place their hands on their knees and just lean into their elbows. And if that doesn't do it, if that little bit of pressure doesn't get the urine flowing, if you actually blow your nose while you're doing that, then it relaxes the urinary sphincter and they're able to start to void. One of our primary concerns with our postpartum patient is maintaining that uterine tone. Major intervention to restore that tone is stimulation by gently massaging the uterine fundus until it's firm. It may cause a temporary increase in bleeding and clots. It may be uncomfortable. We need to teach the purpose and teach the patient how to massage their own fundus. If the uterus remains boggy, this is a major warning sign of urinary. We need to call our provider immediately, because she's probably experiencing quite a bit of bleeding. Our plan of care and implementation continued. We want to promote comfort, rest, and ambulation and exercise. Comfort, common cause of discomfort after childbirth are the afterbirth pains. With each subsequent birth, the afterbirth pains are more intensified. Episiotomy or perineal lacerations, hemorrhoids, and breast engorgement also cause discomfort. We can use both pharmacologic and non-pharmacologic interventions to promote the comfort. Non-pharmacologic interventions for the episiotomy use a pillow when sitting, application of an ice pack for the first 24 hours only, cleansing with a squeeze bottle with warm water, a sitz bath. Instruct the patients to enter with the gluteal muscles tightened. Do not relax until after she sits down into that bath. Many women report those hemorrhoids, and I told y'all that when they have hemorrhoids, those sitz baths are comforting for them. Again, we also want to provide them with things that they can alleviate the discomfort of the hemorrhoids. We want to give them some anesthetic specifically for that. And also, if she digitally, or if we need to digitally put them back in, that also helps to alleviate some of that discomfort. Non-pharmacologic interventions for breast engorgement, applying either ice or heat to breast, wearing a well-fitted support bra, binding the breast if not breastfeeding. Pharmacologic would be narcotic or non-narcotic medications, topical applications, anesthetic ointments, PCA pumps, those are usually used for C-sections, and continuous epidurals. Unrelieved pain may result in fatigue, anxiety, and worsening perception of the pain. It can prevent the mother from participating in her self-care. We want to encourage rest so that don't get fatigued. Excitement and exhilaration may make rest difficult, as well as anxiety about infant care. Measures should be taken to encourage the mother to rest and avoid that. We might have to encourage some back rubs. Maybe Honey Bunny can give her some back rubs. Medications to help her alleviate the pain and to rest. Adjusting hospital schedules as we can. And maybe discouraging visitors during rest times. If mom's had a slew of visitors coming in, she might need a slew of visitors to stop for a while so she can rest appropriately. Ambulation is very important to ambulate. Early ambulation helps reduce the incidence of thromboembolism. It promotes more rapid recovery. If they have orthostatic hypotension when the patient first sits or stands, they're going to need assistance. Medication may cause the patient to be drowsy and may also require assistance with that. We want them to start ambulating. We want them to get their bowels moving, especially our C-section patients who are at a more increased risk. So we want them up and we want them moving. We want to know that they're going to get some gas passing out. A patient on bed rest is at risk for developing blood clots. Exercises that can promote circulation in the legs is indicated. Might have to alternate flexion and extension of the feet, rotate the ankle in a circular motion, alternate flexion and extension of the legs, press back a knee to bed surface and then relax. Kegel exercises are important to regain muscle tone in the perineum, and the patient may resume simple exercises soon after birth and progress to more strenuous ones. Can you think of some cultural awareness? We have some cultures that do not allow the moms to get up after they've delivered, and they want them in the bed. We need to be aware of those cultural differences, and if that were the case, then we need to teach them about the possibility of developing clots and the exercises that they can do in the bed to promote that circulation. We want to promote good, adequate nutrition. Most women display a good appetite and eat well. We want to encourage nutritious snacks. Family members may bring food to the hospital, especially if they have cultural preferences. Prenatal vitamins and iron are often continued until 6 weeks postpartum. We need our mamas to get back to normal bladder and bowel functions. After birth, the mother should void spontaneously within 6 to 8 hours. We want to educate women about measures to avoid constipation, such as eating adequate roughage, increase their fluid intake, and promote exercise. Pain medications can decrease that GI motility, so they're going to be at a greater risk, especially when we're talking about our C-section patients where we've manipulated bowel. They're going to be at a greater risk of developing an ileus, especially if they're not getting up. Stool softeners or laxatives may be necessary during the early postpartum period, and we usually do stool softeners. Rubella vaccination for women who have not had rubella or who are serologically not immune may be indicated. We know what it is. Rubella's vaccine. It's recommended that we do it in the postpartum period. And then RH isoimmunization. Injection of RhoGAM within 72 hours after birth prevents sensitization in the RH negative woman. RH immunoglobulin is a cross-match to the mother's RBCs to ensure compatibility. It's considered a blood product, and precautions similar to blood transfusions are necessary when administering it. Maternal self-image is an important assessment. It concerns a woman's self-concept, her body image, and sexuality. How the woman feels about herself and her body during the postpartum period may affect her behavior and adaptation to parenting. Adaptation to parenthood and parent-infant interactions. The assessment needs to include evaluation of adaptation to parenthood. We want to see this by mother and father's reactions to and interactions with the new baby. Examples of positive infant interactions include taking pleasure in their infant and tasks done for him or her, understanding their infant's emotional states and providing comfort, and reading their infant's cues for new experiences, and then sensing his or her fatigue. These need to be evidenced prior to discharge. Family structure and functioning. A woman's adjustment to her role as mother is affected greatly by her relationships with her partner, her mother, and other relatives and other children. The impact of cultural diversity. Much of a woman's behavior during the postpartum period is strongly influenced by her cultural background. All cultures have their own beliefs and practices that affect their self-care and care of the infant. We as nurses must accommodate these patients and their beliefs as much as possible. Psychosocial needs, signs of potential complications, refer to themselves as ugly and useless, excessively occupied with their self and body image, markedly depressed, lack of a support system, refuses to interact with or care for the baby, expresses disappointment over the baby's sex, and sees baby as messy or unattractive. Self-care and the signs of uh, care and signs of complications. Discharge planning begins on admission, along with teaching about maternal newborn care. Every woman needs to be taught to recognize physical signs and symptoms that may indicate problems. Sexual activity and contraception. Typically, MDs recommend waiting 6 weeks before resuming sexual intercourse. Although most couples resume sexual activity before that, sometimes we see that within hours after birth. Contraceptive options should be taught upon discharge, since a 6-week checkup may be too late. Breastfeeding and non-breastfeeding women should be encouraged to use contraception even though their menstrual period may not have resumed. Breastfeeding is not indicative of it does not mean that you're not going to ovulate and you're not going to get pregnant. Medications that are prescribed. Women should continue to take prenatal vitamins and iron during the postpartum period. Some women may be discharged with a prescription for stool softeners. If not, we encourage them to pick those up as over-the-counter. Narcotic pain medications may be prescribed. Some mothers should be aware that they may be drowsy and should use caution if they are alone with the infant. The nurse should make sure the woman knows the route, dosage, frequency, and common side effects of all medications. We don't want to send her home with Percocet and encourage her to take Tylenol in between. Percocet has Tylenol in it. We do not want to do that. Routine mother and baby checkups. Women with uncomplicated vaginal births are commonly scheduled for follow-up in 6 weeks. It can be 4 weeks. Women with a C-section, according to your text, are often seen after 2 weeks, but that's not always the case. Anymore, I've seen it where the woman with the vaginal birth is seen at 4 weeks and the C-section is seen at 6 weeks. But that's going to depend on the physician, and that's going to depend on their policy. Date and time for follow-up appointments should be included in your discharge instructions. Pediatricians typically like to see their newborns for an initial examination within the first week of age. Follow-up after discharge. There's home visits, there's telephone follow-ups, there's support groups, and there's referral to community resources. The health department had a job opening some years ago that I thought was pretty awesome, and it was a home health postpartum nurse who came around and assessed the mom for any complications, which would include postpartum depression, and also assess the infant and weigh the infant to ensure that they were getting up to their birth weight. Thought it was a cool sounding job. So now we're going to talk about some postpartum complications, because not everyone has an easy transition. Uterine atony is marked hypotonia of the uterus. The uterus does not contract sufficiently to enable permanent thrombi to form at the placental site. The medical management for this, we want to massage the uterus. We want to eliminate bladder distension. We want a continuous IV infusion of Pitocin. Other medications we might give would be Methergin or Hemabate. Normally, placental separation and expulsion are facilitated by the contraction of the uterus, which also prevents hemorrhage from the placental site. The corpus is in its essence a basket weave of strong, interlacing, smooth muscle bundles through which many large maternal blood vessels pass. So if the uterus is flaccid after detachment of all or part of the placenta, then brisk venous bleeding occurs and normal coagulation of the open vasculature is impaired and continues until the uterine muscle is contracted. Associated usually with hyperity, hydramnios, and macrosomic fetus, LGA, multifetal gestation. Other causes could include a traumatic birth, use of halogenated anesthesia, magnesium sulfate, rapid or prolonged labor, chorioamnionitis, and use of oxytocin for labor induction or augmentation. Methergin would be as one that we would use to hopefully stop the bleeding. It is contraindicated, though, if the blood pressure of your patient is 140/90, because the side effect of it is hypertension. Hemabate can be given intramyometrially at the C-section or intra-abdominally after a vaginal delivery. Hemobate, though, is associated with severe diarrhea, so it's typically given with some Lamodal. Other bleeding with contracted uterus, we might be seeing laceration of the vagina, cervix, or perineum. We need to do a visual inspection, see if we see anything else, and treatment depends on the source. Bleeding can be a slow trickle, an oozing, or frank hemorrhage. Hemorrhage related to laceration should be suspected if bleeding continues despite a firm or contracted uterine fundus. We need to let our physician know. Factors that influence the causes and incidence of obstetric lacerations would be operative birth, precipitous birth, that's one that happens very quickly, congenital abnormalities of the maternal soft parts, and a contracted pelvis. Size, abnormal presentation and position of the fetus, relative size of the presenting part and the birth canal, previous scarring from infection, injury or surgery, viscosities that can also cause lacerations. Lacerations are classified as first, second, third, and fourth degree. An episiotomy may extend to become either a third or fourth degree laceration, depends on how far it goes. If it goes up into, down and up into the rectum, then we're looking at a fourth degree laceration. Pelvic hematomas may be vulvar, vaginal, or retroperitoneal. Vulvar hematomas are the most common. Pain is the main symptom that the woman experiences. Most vulvar hematomas are visible. Vaginal hematomas occur most commonly in association with the forceps-assisted birth, an episiotomy, or a prima gravida. Retroperitoneal hematomas are the least common, but they are life-threatening, y'all. They're caused by laceration of one of the vessels attached to the hypogastric artery. It's usually associated with a rupture of a cesarean scar during labor. During the postpartum period, if the woman reports a persistent perineal or rectal pain or a feeling of pressure in the vagina, we needed to be careful, do a careful assessment. However, retroperitoneal hematoma may cause minimal pain, and the initial symptom may be shock. Cervical lacerations usually occur at the external OS, and most are shallow, and the bleeding is usually minimal. So there's a lot that can occur when we have a complicated patient, and it could be occurring for different reasons. Retained placenta, adherent retained placenta, placenta accreta, a placenta in which the cotyledons have invaded the uterine musculature, resulting in a difficult or impossible separation of the placenta. They are at great risk for infection and postpartum hemorrhage. Non-adherent retained placenta, they have partial separation of a normal placenta, entrapment of partially or completely separated placenta, mismanagement of the third stage of labor. It is common with preterm birth and manual removal. Woman is at risk of infection and postpartum hemorrhage. Pelvic hematomas, there's going to be a collection of blood in the connective tissue. It can be vulvar, which is the most common. I've already talked to y'all about that. I've talked to you about the vaginal or retroperitoneal. The common symptom that they're going to experience is pain. During the postpartum period, I told y'all also that the woman may not experience pain with the retroperitoneal. The first sign that you might actually have with it is that she's in shock. Uterine rupture. Rupture of the uterus, usually in the lower uterine segment. Most common when they've had previous C-sections, and the most common symptom is abdominal pain or hemorrhage and shock. Our risk factors for uterine rupture, high parity, think of 19 kids and counting, treatment with magnesium sulfate, prolonged use of Pitocin, multifetal gestation, traumatic birth, chorioamnionitis, rapid or prolonged labor, abnormal uterus, or an LGA infant. Uterine inversion. The uterus turns inside out after birth. It is potentially life-threatening, occurs most often in multi-parous women with placenta accreta. Other factors, fundal implantation of the placenta, vigorous fundal pressure, excessive traction applied to the cord, uterine atony, and abnormal adherent to the placenta. Complete inversion of the uterus is obvious with a large red rounded mass, perhaps the placenta attached, that protrudes 20 to 30 centimeters outside the introitus. Incomplete inversion cannot be seen but must be felt. A smooth mass will be palpated through the dilated cervix. Primary presenting factor are hemorrhage, shock, and pain. Prevention, the easiest and cheapest and most effective therapy, is especially appropriate for uterine inversion. We don't want to pull the umbilical cord unless the placenta has definitely separated. Now let me tell you about my patient who had an inverted uterus. She was 1 week postpartum. She had delivered, I want to say she was a C-section delivery. I had taken care of her that night when after she had come in, because during the morning she had gotten up and passed a dinner-sized clot on the floor of her, a dinner-sized plate clot on the floor of her living room. So she goes to the doctor. They determine that her H&H is 5 and 15. They go in to do a D&C on her. They initiate blood transfusions. They transfer her up to the floor for us to take care of. So she had just finished her first unit of blood and asked if she could breastfeed her baby before she went to her second unit of blood. So that is what we decided to do. It was a full house that night. I had a new orientee. Well, she wasn't an orientee, but she was a new nurse. So it was just she and I with 18 patients. And because she was new and very unfamiliar with some of the patients up there, I had given her, I believe, 7 of the patients, and I took 11. And with her agreeing to help me as I needed. So I had finished up with all the patients, and my nursing assistant came and said, "Hey, I need you down in 53. And I'm like, "I'll be right there." "No, I kind of need you right now." "Okay, well, I'm on my way then." I walk into the room, and the patient is sitting in the bed, and she's got, her head is elevated and her feet are elevated, and she says, "I don't think this is right." Now, we had just assessed her fundus, and it was firm. She had just gotten up and went to the bathroom. She had no bleeding. She had come back to the bed, sat down, just sent her husband and the baby out to go home, and felt something between her legs. And when she looked, and when I came in, she had a pool of blood between her legs that was actually bubbling. You could actually see it. It was coming out. So immediately put her in Trendelenburg, started a fundal massage, and it would firm up and bog down, firm up and bog down. I could feel the bogginess. I could feel the clots. And so the other nurse had come in who typically worked postpartum in the first place. And so we went back and forth doing fundal massage. She said, and I said, "I'm going to go call the physician." Called the physician who wanted me to do, I think I gave Methergin IM. I started a bag-of-pit. We did all these different things. I had several different orders. In between times, he said, "Keep massaging the fundus." She passed another clot the size of a football. She's in Trendelenburg. She's diaphoretic at this point, and I've already talked to the physician 3 times. And on the 4th time that I called him, he said, "I told you I'd call you back and check on her." And I said, "And I'm telling you now, you need to be up here. Her vital signs are this: she's diaphoretic, she's continuing to bleed. We cannot firm this fundus up." So he came up there. We had 2 units of blood that both of us, because we just didn't have time to find any pressure bags, we were pushing the blood into her. We were just squeezing the bags and getting it in as fast as we could. So I didn't know what happened. We had no idea what was going on with her. Took her down to the OR. She ended up having 8 units of blood. She was admitted back to the floor the next morning after he had to complete a hysterectomy on this young mom who had only had one baby. And her uterus had inverted. I will never forget that ever in my life. I cried after that was all said and done. I had my moment of breakdown, and I cried that night for several hours because it was so. It was devastating to me to watch my patient going through this and knowing that she was so critical, and of course the stress of the moment. I will say that years later, for a couple of years after that, I would get Christmas cards every year from her and her husband and her daughter and their dog, and telling me Merry Christmas and thank you once again. So, I mean, she never looked at it as a bad thing, but you just need to be aware that not everything is roses and sunshine in postpartum. You have to be aware for postpartum complications. You have to be aware for what is the abnormal, and you have to push and advocate for your patient as well. So, signs and symptoms of the uterine inversion, pretty much just told you. Hemorrhage, shock, pain, replacing the uterus per the MD, give oxytocin. She had to have her uterus removed. And broad spectrum antibiotics. Of course, she wasn't an immediate postpartum patient. She had been out for a week. Subinvolution of the uterus is a delayed return of the enlarged uterus to normal size, causes retained placental fragments and pelvic infections. Signs and symptoms: prolonged lochial discharge, irregular or excessive bleeding, and hemorrhage. The treatment depends on the cause. A possible DNC may be necessary. Late postpartum bleeding may occur as the result of a subinvolution of the uterus. A pelvic exam usually reveals that a larger than normal uterus that may be boggy. Nursing interventions include assessment of vital signs, uterine consistency, and administration of oxytocin. We have to provide support for our patient and family. If the uterus has been repositioned manually, then care must be taken to avoid aggressive fundal massage. Discharge instructions for the woman who has had postpartum hemorrhage are similar to those for any postpartum woman. In addition, she should be told that she will probably feel fatigue or even exhaustion and will need to limit her physical activities to conserve her strength. She may need instructions in increasing her dietary iron and protein intake. Referrals for home care, follow-up, or community resources may also be indicated. So we need to be aware of symptoms of hemorrhagic and hypovolemic shock. Be aware of symptoms of hemorrhage and hypovolemic shock. I'll repeat that. Respirations, rapid and shallow. Palpation of pulses, rapid, weak. Remember, tachycardia is not a normal rhythm. Skin color, we're looking at temperature, we're looking at turgor. Is it cool? Is it pale? Is it clammy? Level of consciousness, are they lethargic? Are they slipping into a coma? What are we seeing with this patient? Capillary refill, is it prolonged? We're going to want to get a pulse ox, and we need to look at urine output. What is urine output for your patient who has had a hemorrhage? It is the overall indicator of how the body is doing. So if their urine output is in the tank, you need to be a little bit on the concern side. Look for presence of anxiety, look for restlessness, and look for disorientation. We have to assess the fundus for firmness when we need to look at assess the position and at or near the umbilicus. Bleeding is assessed. We're looking at color and amount, perineum, signs of hematoma or laceration. Vital signs may not be reliable indicators of shock immediately in the postpartum period. Look at your urine output. Watch for trends in the 2 hours after birth. Assess for bladder distension. Hemorrhagic shock results in the blood flow diverted to the brain and heart away from other organs, results in cellular death if not treated. It is an emergency situation in which the perfusion of body organs may become severely compromised and death may occur. They may not show signs of shock until after the patient has lost 30 to 40% of their blood volume, and they're going to definitely require some blood replacement. What do we want to do? We want to get the restoration of the circulating blood volume, eliminate that source of hemorrhage, rapid IV fusion of lactated ringers or normal saline solution, rate 3 mils per 1 mil of estimated blood loss. Packed red blood cells are necessary in the face of uncontrolled bleeding and no improvement after fluid infusion. We want to monitor the pulse and blood pressure, assist for invasive hemodynamic monitoring if they have to have a Swan-Ganz, monitor their CVP, evaluate their skin temp, color, turgor, mucous membranes, assess for presence of petechiae or ecchymosis in areas not associated with surgery or trauma. We're thinking of DIC at this point. Hematologic disorders, abnormal bleeding caused by problems with clotting, such as with decreased platelets, DIC, disseminated intravascular coagulation, HELP syndrome, that is a variant of severe preeclampsia noted by hemolysis, elevated liver enzymes, and low platelets, increased risk for adverse perinatal outcomes, and including placental abruption and renal failure. Von Willebrand disease is a type of hemophilia. Factor VIII deficiency. Woman may be at risk for up to 4 weeks after delivery. If the bleeding is continuous and there's no identifiable source, then a coagulopathy may be the cause. The nurse needs to draw the blood. We got to get it done and sent to the lab for studies. DIC is a pathologic form of clotting that is diffuse and consumes a large amount of clotting factors, including platelets, fibrinogen, prothrombin, and factors 5 and 7. Widespread external bleeding, internal bleeding, or both can result. Causes: abruption of the placenta, amniotic fluid embolism, dead fetus syndrome, severe preeclampsia, septicemia, cardiac arrest, and hemorrhage. Medical management: we got to correct that underlying cause. Removal of the dead fetus or placenta, or treat the infection or preeclampsia. We might see petechiae around slight trauma, such as blood pressure cuff, tachycardia, and diaphoresis. As a nurse, you need to assess the risk factors. You need the Fundal Assessment. You need assessment of bleeding. You need the vital signs. And you need assessment of bladder distension. Thromboembolic embolic disease. I am so sorry. Superficial venous thrombosis. Involvement of the superficial saphenous venous system. DVT involvement varies but can extend from the foot to the iliofemoral region. And pulmonary embolism. That's a complication of the DVT. It occurs when part of the blood clot dislodges and is carried to the pulmonary artery. Incidence varies from 1 to 1,000 to 1 to 2,000. It has declined in recent years due to early ambulation of our patients. Risk factors, though: obesity, varicosities, maternal age over 35, multiparity, and smoking. Some clinical manifestations that we're looking at: pain and tenderness in the lower extremity, warmth, redness, enlarged or hardened vein. PE is characterized by dyspnea and tachypnea. Signs of pulmonary embolus: you're going to see they're going to be short of breath. They're going to be tachypnic. They're going to need immediate attention. DVT is characterized by unilateral leg pain, calf tenderness, and swelling. We want to assess both legs for differences in size or temperature. We're also looking for a positive Homan sign that may be present. It's not conclusive, though, due to muscle strain that can occur during the birthing process, but if it is positive, we want to keep a close eye on this patient. Medical management: venography is the most accurate method for diagnosing a DVT. Color Doppler ultrasound is the most common. Ventilation perfusion scan and pulmonary arteriogram. Treatment: NSAIDs, rest with elevation of the affected leg, elastic stockings, local application of heat, and anticoagulation therapy. What are we going to do? We're going to inspect and palpate of the affected area, palpate the peripheral pulses, check Homan sign, measurement and comparison of leg circumferences, monitor for any signs of bleeding, monitor for signs of pulmonary embolism. We want to look at lab tests and coag studies. We have to assess those legs for differences in size. Another complication that can occur in the postpartum period are infections. Any clinical infection of the genital canal that occurs within 28 days after miscarriage, induced abortion, or childbirth. Best treatment is prevention. Prevention occurs when all healthcare personnel use strict aseptic technique, and we also teach mom. We must encourage our moms to change that peri pad at each toileting. The types of postpartum infections we might see: endometritis, peritonitis, pyelonephritis, cystitis, thrombophlebitis, and mastitis. How's it diagnosed? We're going to see a temp of 101 or greater in the first 24 hours after delivery for 2 consecutive days in the first 10 postpartum days. Predisposing factors: poor nutrition, history of infections, anemia, or immunodeficiency. In the U.S., this occurs in 3% of deliveries vaginally and 5 to 10 times that for C-sections. Preconception or antepartal factors: if they have a history of venous thrombus, UTIs, mastitis, pneumonia, diabetes, alcoholism, or drug abuse. The intrapartum predisposing factors: their prolonged labor can cause infections, premature rupture of membranes, and poor aseptic technique, birth trauma, multiple exams, internal monitoring, episiotomy, and C-section. The C-section woman needs to be taught signs and symptoms of wound infection to report. We need to watch that incision site when she goes home. We need to teach her how to take care of it well. Postpartum predisposing factors would be the manual removal of the placenta, hemorrhage, or any retained placenta. Excuse me. Endometritis, infection of the lining of the uterus, is usually localized. Incidence is higher after C-sections. As signs and symptoms, we're going to see a fever greater than 101, increased pulse, chills, anorexia, nausea, pelvic pain, foul smelling, and profuse lochia. It can spread to the entire endometrium. Peritonitis is a life-threatening infection of the peritoneum. The signs and symptoms: guarding, abdominal pain, and fever. Pyelonephritis, kidney infection. It's usually the right kidney. Signs and symptoms: pain in that right flank, fever, chills, frequency or urgency of urination, and a foul-smelling urine. Prevention and treatment: sterile technique with catheterization, obtain urine culture, give cranberry juice to enhance acidity in the urine, and help to eliminate the infection. It's usually the result of an infection of the lower urinary tract, so the organisms will travel up the dilated ureters to the kidney. Wound infections. Signs and symptoms: sites of infection include a cesarean incision, episiotomy, or repaired laceration. We're going to see some redness, edema, warmth, tenderness, seropurulent drainage, and wound separation. Fever and pain may also be present. Predisposing factors are similar to those of endometritis. A cesarean delivery is they're a postoperative patient, so they're the PO patient. This is important to remember. We manipulate the bowel. We incise through all layers to reach the fetus. So, you have to think about the risk factors that are involved for the postoperative, postpartum client. And so what are those? Right now we're talking about wound infections. I've already talked to you about ileus, to make sure you assess bowel sounds if the patient has passed any gas. We also are concerned about bowel nicks and bladder nicks and wound dehiscence. UTIs and cystitis occurs in 2 to 4% of postpartum infections. The risk factors for it: if they've had a urinary catheterization, frequent pelvic exams, epidural anesthesia, and genital tract injury, and also a C-section. Signs and symptoms of UTIs: dysuria, frequency, urgency, low-grade fever, urinary retention, hematuria, and E. coli may also be the cause. Mastitis, a breast infection that affects about 1% of women soon after childbirth. Almost always is unilateral, usually caused by Staph aureus. Signs and symptoms: chills, fever, malaise, breast tenderness and swelling. They're going to feel like they have the flu. We're going to treat them with antibiotics, and usually we're going to treat them with antibiotics that they can take while they're breastfeeding. If the mom ends up being readmitted for mastitis and she's on stronger IV antibiotics, then she may have to pump and dump her milk. It can be avoided, though, using proper breastfeeding techniques. What I tell y'all earlier, if I see a mom that has nipples that are starting to break down, there's blisters on there, I'm going to assume the baby is not latching right. So that's some of the things that we look at when they get blistered and they get cracked. Missed feedings, waiting too long between feedings, and abrupt weaning may lead to clogged nipples and mastitis. Cleanliness practiced by all who have contact with the newborn and new mother also reduces the incidence of it. When we're talking about the postpartum woman who's experiencing any infection, we want to carefully monitor them and assess them for any predisposing factors. We want to look at any of the symptoms that go along with it, look at their lab results, their history. Antibiotics, if they're admitted into the hospital, is usually going to be IV. Prevention is best. Strict adherence to the aseptic technique, good maternal perinatal hygiene. Teaching should include signs and symptoms of worsening infection, prevention of spread. Women are usually discharged home within 48 hours, which is before signs and symptoms of infection would actually probably occur. So that's why our discharge teaching needs to include it. Women are at risk for problems related to the reproductive system due to trauma and childbirth. It can be caused by fetal pelvic disproportion, prolonged labor or precipitous birth, uterine displacement and prolapse, cystocele, rectocele, urinary incontinence, stress incontinence, urge incontinence, genital fistulas that may occur between the bladder and the genital tract, between the urethra and the vagina, and between the rectum and the vagina. It's nothing like having a fistula that comes back into the hospital, and I probably shouldn't identify a patient as a fistula, but that's what she was, and she actually had stool that was coming out of the vagina because of this fistula that had developed. Lacerations, cervical, vaginal, perineal. Symptoms and treatment. Symptoms are prolonged bleeding from the vagina, bright red blood. Treatment depends on severity and may need to be sutured. The postpartum psychologic complications. It's an intense and pervasive sadness with severe and labile mood swings. It's more serious than postpartum blues. Symptoms that persist past the baby's first week are not normal. Signs and symptoms similar to non-PPD, food cravings, binges, increased sleep and irritability, severe postpartum depression, severe anxiety, panic attacks, spontaneous crying long after the usual duration of the baby blues. It occurs in about 10 to 15% of new mothers. These symptoms rarely disappear without outside help. The occurrence for teenage mothers was more than 2.5 times that for older mothers. Mothers who had no one to talk to about their problems after giving birth had a higher rate of PPD and a low rate of help seeking. It's important for the nurse to provide a listening ear for the woman's concerns. We also need to let her know that it is okay to let her physician know that she's experiencing these symptoms. This does not mean that her baby will be taken away, but this means that she's going to get help. Medical management, pharmacologic treatment is usually necessary, antidepressants, electroconvulsive therapy. I don't know that. I'm sure that probably does happen. I hope that it doesn't have to go that far for some of these. Psychotherapy, so we can focus on their fears and concern, and we have to watch them for suicidal and homicidal thought. The postpartum depression with psychotic features is a syndrome most often characterized by depression, delusions, thoughts of harming either the infant or herself. It occurs in 1 to 2 per 1,000 births. We've seen a lot of these in the news about people that have killed their children because the devil, was after them, or they felt like voices were telling them to kill them. Signs and symptoms begin days after birth. They'll have fatigue, insomnia. They'll be restless. Later, they're going to be suspicious. They're going to have confusion, irrational statements, obsessive concerns about the baby's health. Main concern is that the mother may harm the baby or herself. There is a 30 to 50% likelihood of reoccurrence with each subsequent birth. Bipolar disorder and as a depressive disorder characterized by periods of manic behavior. During manic period, these women are hyperactive and they may not take time to eat or sleep. They also may require constant supervision when caring for the infant. Medical management of PPD with psychosis. Postpartum psychosis is a psychiatric emergency requiring hospitalization. Antipsychotics and lithium are drugs of choice if the patient is not breastfeeding. Though if she's breastfeeding, it would probably be encouraged that she stops so she can begin her medications. We want to be able to recognize symptoms of PPD early. We need to be active listeners and have a caring attitude, ask appropriate questions to determine moods, appetite, sleep, and energy and fatigue levels. If depression present, nurse must ask if the mother has thoughts of hurting herself or the baby. Need to give PPD info to mother and family before discharge. Perinatal loss is a profound experience for the family. It's a unique kind of mourning as the infant is a part of the parent's identity. Instead of celebrating a new life as they expected, they are mourning the loss of dreams and hopes and loss of an extension of themselves. It is incomprehensible to most parents. It can't be real. Nurses play a major role in assisting parents to make their dying newborn real to them by providing as many memories as possible. We encourage them to hold, we encourage them to touch, we encourage them to dress and take care of the infant and take photographs. We need to assist the parents to cope with perinatal loss, respect the variations in family spiritual needs. We ask our parents if they want to hold their deceased infant. We swaddle the infant. We clean the infant. We allow them to hold them as long as they want or need to while in the hospital. We need to also make sure that they acknowledge that there is a loss and that they're going through grief. We need to find out what their plans are for a funeral or memorial service. That is the end of my presentation. I will see you in the class.